Next, we have Dr. Michael Belin with his presentation and probably the last talk of this meet.
Good. So I have it. I thought we would end with a term that's become very popular in the US. I don't know if it's really made to India or not with our president, but fake news. And I want to review a little bit about reviewing papers. And we hear a lot during this meeting about articles and studies, but let's talk a little bit about fake news. Now, how do you determine real versus fake? Well, in certain things, it's very, very easy. But most of us have been inundated with these fake journals. And this is just 1 week's worth of, actually, I think it was 2 days worth of emails. And you can see here, these are typically what they are. I'd like to invite you, Journal of Ophthalmology and Optometry Research, or Journal of Engineering. These, most of us get these at least multiple times a day. And we view these journals as real. So usually when you read articles in these journals, we kind of think they're peer-reviewed, they're reliable, and that's really what, we've heard that throughout this whole meeting about these peer-reviewed articles. But particularly when it comes to keratoconus, even the peer-reviewed literature has huge limitations. And I'm going to go over a couple of methods used, and here I say many, and I'm going to say in most of the papers, and I get sent a lot of papers to review, and after reviewing papers for a number of years, what I do now is I just jump right to the methods section. And the reason for that will become evident. So the first problem, I'm grouping these studies, and the first one I call a method so easy, even a child can do it. And it's implying that you use the most up-to-date diagnostic testing. If you read papers, they'll define their normal study group using every available examination: normal vision, normal slit lamp, normal topography, normal tomography, Scheimpflug OCT, no surgery, contacts, family history. And okay, I don't have a problem with saying those patients are normal. They define their study group, in other words, their keratoconic group, by also every available examination technique plus slit lamp findings: Munson sign, Fleischer, Voigt-Strier, or Rizzuti's sign. And this is an example. I don't put the names of the articles because I don't want to embarrass the authors, but the inclusion criteria for the keratoconus group were defined as the following: a Kaiser index of greater than 100, an IS difference of greater than 1.4, a Kmax of 47, as well as at least one of the following biomicroscopy findings: Voigt-Strier, Fleischer ring, or stromal thinning. In other words, the advanced imaging is useless if your criteria mandates that you have slit lamp findings. So the advanced imaging is meaningless if your study population has obvious slit lamp findings. This does not represent a diagnostic dilemma. Okay? A high degree of specificity and sensitivity has little, if any, clinical significance if your two study populations can be separated by simplistic means. In other words, a keratometer and a slit lamp. Effectively, it's the same as this. Okay? We don't need pregnancy tests on someone who's 8 months gestation. Okay? It can be separated by simplistic means. It's a meaningless study. Next group I call fait accompli, and maybe you can pronounce it better. Yeah, see, I can't say with that good, okay? And that is, if you define a disease by A and B, then A and B become very good predictors of that disease. Sounds obvious, but these are peer-reviewed major journal articles. So let's go. And a lot of times it's kind of confusing because they give you a lot of information. In this cross-sectional study, keratoconus diagnoses have been confirmed by a thorough clinical examination and corneal topography based on the criteria developed by McMahon. I have no idea what that was actually. This was tested against a manual assignment from the Clinix study. They used 2 corneal topography indices: average corneal power and root mean square error for higher order Zernike terms, derived from the first corneal. We'll skip that. Mind you, they also included Voigt-Strier, Fleischer rings, and corneal scarring. What were the results? Mean keratometry and third order vertical coma aberration were identified as the best diagnostic, yeah, he's laughing already, it's ridiculous, it was published. Best diagnostic criteria for definitive keratoconus with an R2 of 0.91 with a p-value of 0.001. So what's wrong with this? Well, of course, if you define your study group by mean keratometry, that's average corneal power. So yes, if you define it by A and B, then A and B becomes great predictors, published in a major journal. So again, as I say, it's a fait accompli. The next is using the wrong test. And this one's going to take a little bit longer to go through, but we heard today, you hear people talk about it's 97% sensitive or 97% specific. What does that really mean? So this was something we published. Basically, this is looking at certain parameters for refractive screening. And I'll just look down that first column. That first column says, okay, if I want a 95% confidence interval, in other words, I'm willing to eliminate 5% of my normal population so I don't inadvertently treat cones, we can see minimal pachymetry is a terrible parameter. You would have to put down at 489, but I wouldn't, if I use minimal pachymetry, I would still include about a third of the cones. But the problem is a lot of people use refractive screening parameters as inclusion parameters. But let's look here. Here, instead of screening, I want to do studies on cones and true keratoconic patients. And here I say, okay, let's look at that first column. I want to make sure I get 95% of all the cones. Well, again, minimal pachymetry is a terrible parameter because for me to get 95% of the cones, I would include 49% of my normal patients. But let's look down at the best single parameter, which is, in this study, was the progression index average. It only had a 3.2% false positive rate. So that sounds great, right? It's 97% this and 97% that. It sounds like a great forming parameter. Well, at least in the US, I know the incidence is very different here in India, but in the US, we have a keratoconus incidence anywhere from 1 in 500 to 1 in 2,000, so I just use 1 in 1,000. If you have 1 in 1,000, you're doing studies on keratoconic, and you have a parameter that has a 3.2% false positive rate, that means you will have 32 normal individuals for every true keratoconic that you study. So again, if you have 100 people in your study and you're using that parameter, which on paper sounds 97%, it sounds great, only 3 of your subjects out of 100 actually have disease. You actually have to approach almost a zero. And if we go down here to the bottom right, even a 0.6% false positive rate on an inclusion study is not sufficient. That will allow 6 normals for every keratoconic patient. You really have to approach a 0% false positive rate, and we don't do that in our studies. A lot of studies, what you will read, and you will never hear me say, except I'll say it now, the word form press keratoconus. To me, it's a useless term. It's like, I'll go back to the pregnancy. It's like meaning you're almost pregnant. To me, it has no meaning. But what you will read in a lot of papers is they do studies on patients who have failed their refractive screening. And again, if we go back and say, okay, if I use criteria that has a 95% confidence interval, so I'm eliminating 5% of my population, and I study those, only 2% of those patients that you've excluded are likely to have true disease. So again, a lot of studies, inclusion studies in keratoconus, have very poor inclusion criteria. So again, if you use a 95% confidence interval for refractive screening, and then do a study on those patients who failed your screening, the likelihood is only 2% of those treated actually have disease. So sensitivity, specificity, ROC, AUROC do not reflect clinical applicability. What we really should be using is a term that rest of medicine uses, but for some reason we don't in ophthalmology, and that's positive predictive value. And that's the proportion of patients who actually have disease who test positive. And if we use that, again, 3.2% false positive rate and 1 in 1,000 incidents, the positive predictive value for that's only 1 over 32, which is actually a very poor performing parameter. So I'll skip by this. Next, you had a quote, I don't know who was earlier, who made a quote about statistics. We heard a lot about the ERSS, the Occasi risk scoring system. And a couple of quick quotes. I can prove anything by statistics except the truth. You heard this one, I think, earlier. If your experiment needs statistics, you ought to have done a better experiment. And probably my favorite one by Mark Twain is most people use statistics like a drunk uses a lamppost, more for support than illumination. So I won't go over this, but you already saw this. This is the Randleman Stolting Occasi risk score. And I won't go over it. They already went over this. But what were the results? Well, we want to know, is it specific, is it sensitive, is it applicable, and is it statistically valid? And the authors make a point repeatedly that this is the only, quote, statistically validated study. And what were their results? Well, they said they had 6% false positive rates, 8% false negatives. Age was a significant risk factor. Abnormal anterior topography was a significant risk factor. And again, we're only dealing here in this study, which is already alluded to as anterior curvature. So it looks pretty good. 6% false positives, 8% false negatives. So let me ask you about this 6% false positive rate. If you had 1,000 patients and you had a 6% false positive rate, how many patients would be excluded? I'm going to pick on you. The math isn't difficult. $60, okay? You all agree? No. So let me give you another question here. If there was a 1 in a million chance of a catastrophic jet engine failure, and you had a test that had a 5% false positive rate, how many Boeing 747s or Airbus A380s would be grounded? You can give me a percentage. Again, most of you would say 5%. It's actually 18.6%. Does anyone know why? Okay. There are 4 jet engines per plane. Any one false positive would ground the plane. Okay? There are 2 eyes per patient. A 6% false positive rate excludes 11.6% of patients. We don't exclude eyes, we exclude patients. So in our study, a 6% false positive rate sounds good, but actually it was really the 11.6% false positive rate. So again, another Mark Twain quote, there are 3 kinds of lies, damn lies, and statistics. So I think I'll end with this one. I call this one Doing the Impossible. And this was a recently published article, actually now it's about 2 years ago, in journal Cornea. And it's corneal cross-linking for pediatric keratoconus long-term results. And very few studies are prospective, but this was a prospective. I'm just reading what's over there in the patients and methods. It's a prospective cohort study, including all consecutive pediatric patients under the age of 18 who underwent epithelium-off cross-linking procedure for progressive keratoconus at the University Medical Center Utrecht in the Netherlands from January 2010 through December 2013. The diagnosis of keratoconus was established in concordance with the Global Consensus on Keratoconus and Ectatic Disease report. So again, very important. It's a prospective study. All the patients between 210 and 213, and the diagnosis for this study was established by a major article on the Global Consensus of Keratoconus and Ectatic Disease. Any problems there? Well, the Global Consensus was published in 2015, 5 years after a so-called prospective study was started. It's impossible. And what's really ridiculous, it was published in the same journal this was published. How that got past reviewers is beyond me. Do you understand you can't do a prospective study 5 years before what you're basing it on appeared in the press? So in summary, when evaluating papers and research, even though they go in the journals we think are valid, be really careful when you read, and be really careful how they define the study groups, because that's often the thing we go over last. We read the introduction, we read the abstract, we read the discussion, and we never pay attention to how they're defining their study groups. And most of the time, that invalidates a lot of the studies. So again, real important to read the fine print.